Hi all, welcome back to the Emergency Medicine Lecture Series. Now, the most difficult task for an emergency physician or even a primary care physician or at the secondary healthcare level is identification and initial management and stabilization of a sick patient. Even experienced doctors sometimes fail to identify a sick patient and provide timely care. This has a lot of implications on the healthcare. In this video, I will try to briefly discuss about how to identify and how to stabilize a sick patient and appropriate referral and communication. I am Dr S Prakash Babu, Associate Professor of Emergency Medicine at Karpagi Vinayaka Institute of Medical Sciences, Changalpattu. Early identification and appropriate management of sick patients is most often suboptimal. That is, most of the clinicians fail to identify a sick patient and leading to more critical stage of the patient. If the patient has been identified in the earlier stages when a critical illness is developing or progressing before reversible damage occurs, there's a high chances that the patient might live a normal life. But if you fail to identify a sick patient, especially the critically ill patients, you might lose your life. There are multiple reasons for this lack of identification of a sick patient, most of them being mostly the doctors lack a systematic approach to these patients. Most of the time, especially in the government setup, the staff are overburdened and there is deficiencies in medical training also contribute to the lack of knowledge about identification of a sick patient. Cardiac arrest does not develop immediately except those which go into sudden cardiac arrest. In most of the cases, cardiac arrest is usually preceded by many hours of physiological derangement, which is not corrected and not attended. And this is the cause for deterioration of the patient and going into an irreversible stage. So, what do you mean by a critical illness or a serious illness? A serious illness or a critical illness is any disease process which causes physiological instability that leads to disability or death within minutes to hours. Fortunately, these patients can be identified early and they can be treated successfully and they can be saved. Only thing you need to do is follow a systematic approach. Don't miss the crucial steps. Always have a high level of suspicion when the patient is presenting to you, especially during off hours. In the OPD, senior doctors will be available and they will know how to identify a sick patient by just sight. Most of the doctors, senior doctors can identify with experience, but especially when junior doctors, you should have a high level of suspicion. Also, the patient is presenting to emergency department during off hours when OPDs and senior doctors are not available. You should have a high level of suspicion that every patient coming to you should be treated as a critically ill patient who is in imminent danger for his life. Then only you will be able to identify a critically ill patient. Also, all these patients need a triage at specific time intervals. As you all know, triage is not a single time process. There are multiple steps where you need to do triage. You need to keep triaging these patients at specific intervals for timely identification of a sick patient. So, what is triage? Triage is a process of segregating or separating patients based on the severity of illness, how sick they are, and how acutely they need any intervention for life-saving measures to bring them back to normal. The word triage has originated from a French word which is called trier. Trier means the process of sorting into categories. Triage can be basically divided into three phases. Mainly the one which occurs at the pre-hospital phase, which is done by emergency medical technicians or the emergency medical service personnel. Next, at the entrance of ED, a senior nurse is delegated as a triage nurse who will be doing the triage at the entrance of the ED. And once the patient is seen in the ED, he will be triaged whether to admit the patient or to discharge the patient. If you decide to admit the patient, whether to admit the patient to a clinical ward or the patient needs high dependency unit or an ICU. That is the steps of triage. The universal goal of triage is to provide effective and prioritized care to patients while optimizing the resource usage and time. There are multiple triage systems followed worldwide, but if you are a junior doctor, follow simple triage protocols. Most commonly used triage system for especially the trauma victims is START, that is simple triage and rapid transport or treatment. If you are in the pre-hospital setup, you will not spend hours together to triage a patient. You'll use some simple techniques. You'll decide whether the patient needs immediate care or a delayed care, and then you immediately transport the patient. Suppose you are working in ED, again you do a start triage and sort the patients who need immediate treatment and treat them, and patients who can wait for about 20 to 30 minutes or until you saved the critically ill patient and then go back to the normal patients. Children with trauma are triaged using Zemstart. It takes less than 60 seconds to triage victims using these scores. A very, very simple scores. You don't have to spend a lot of time on them. It takes just 60 seconds to triage a victim. Emergency severity index is the triage system used for triaging adult non-trauma victims. So let us see these protocols one by one. First of all, the start adult triage. As I told already, this is the triage system used for triaging adult patients into groups. It is a 4-level triage system. That means there are 4 categories in this triage system: the minus category, delayed category, immediate category, and expectant category. The minor category labeled as green, delayed category labeled with yellow, and immediate category red tag color. Expectant are dying or dead patients, black color triage. First of all, what you need to do, you need to follow a stepwise pattern. Step 1 is after the injury where the patient is able to walk or not. If the patient is able to walk after an accident, he falls into the minus category or the delayed category, who can wait for some period to be attended. So you put them into minus category initially, and then you choose to triage them secondarily. Once you treated all the other category of victims, then you attend these patients and you do a secondary triage. Triage is not a one-time process. I told earlier, it is a continuous process. Any patient who has been triaged to an upper category, when you perform the triage for the first time, can downgrade anytime, go back to a lower category, lower acute category, or a patient who has been triaged to a lower category can upgrade into a higher category, can need more resources and immediate management. Once the walking patients are separated, then look whether the patient is breathing spontaneously or not. The patient is not spontaneously breathing, position the airway. Even after positioning the airway, patient is not breathing, he falls into expectant category, category 4, which is the dead or the dying patients. Once you position the airway, patient starts breathing, he falls into immediate category. That means he needs airway management immediately and other measures to stabilize the patient for life-saving measures. The patient is spontaneously breathing. Yes. Look at the respiratory rate. If the respiratory rate is greater than 30, the patient has to be attended immediately because the patient is in respiratory distress. The respiratory rate is less than 30. Although the patient might have been in respiratory distress, he doesn't need any immediate breathing measures. Then you need to check the perfusion. Radial pulse is absent, the capillary refill is greater than 2 seconds. The patient again needs immediate treatment. This indicates that the patient is in shock circulatory shock, and the patient needs immediate treatment. Once perfusion is checked, radial pulse is present, so the capillary refill is less than 2 seconds, which indicates that the perfusion, organ perfusion is normal. You need to look at the mental status. The mental status asks the patient to obey any simple commands. The patient is able to obey commands, you put the patient into a delayed category. The patient doesn't obey commands, he should be put into immediate category. So this is how you do a simple adult triage. First, you look at whether the patient is able to walk or not, then whether the patient is having spontaneous breathing or not, then count the respiratory rate, check the perfusion, and check the mental status. By the time you go into mental status, you have triaged all the patients. As jumpstart triage system is used for pediatric multiple casualty triage. It's almost similar. The patient is able to walk, yes, falls into minor category. Just like the adult triage, a secondary triage system is needed. Look whether the patient is breathing or not. Patient is not breathing. Position the upper airway. Still apnea is there. Look for a palpable pulse. There is a palpable pulse. Give 5 rescue breaths. Once you give 5 rescue breaths, patient started breathing, put him into immediate category. When you position the upper airway, patient is breathing, put into immediate category. Even after positioning the airway, patient is not breathing, still is apneic. Check the pulse. If there is no pulse, patient goes into disease category or category 4. After 5 rescue breaths, the patient still having apneic, patient goes into disease category. Once you check the breathing, then go and check the respiratory rate. Respiratory rate here is less than 15, greater than 15. Falls into immediate category. Respiratory rate of 15 to 45. There is a palpable pulse. No. Patient goes into the immediate category. Yes. Look for AVPU. AVPU is the patient is unresponsive. That is U in AVPU, immediate category. A, V, or P, delayed category. This is the jumpstart pediatric multiple casualty triage system. Then, as I told, for non-trauma adult patients, emergency severity index is used. This is a little complicated process, but once you get used to it, you can use emergency severity index very easily. Look whether the patient requires any immediate life-saving measures, whether there is a problem with ABC, airway, breathing, or circulation. If the answer to this question is yes, patient will go into triage 1. He doesn't require any immediate life-saving measures. Is the situation high-risk situation? Confused, lethargic, or disoriented? A severe pain or distress is there? Patient will go into category 2. Next question is how many different resources the patient needs. Doesn't need any resource. Category 5. One resource is needed. Patient falls into category 4. Many resources are needed. Then look for danger zone vitals. Patient is not in any danger zone vitals, you can go to priority 3. Patient has any of the danger zone vitals, you will go into priority 2. The most important part is history taking and examination, which will tell you what is the problem of the patient and enables you to attend to the patient well. History taking and examination doesn't start when you approach the patient. It starts when the patient is coming, how the patient is coming inside your clinic or the hospital or the ED. Crucial information can be obtained from proper greeting and receiving the patient to a hospital bed immediately as soon as he presents to your hospital. The patient is reciprocating to you and talking normally. That means he doesn't need any immediate life-saving measures. Not only that, if you're greeting the patient properly and receiving the patient immediately, and start checking or start doing a triage. This can be reassuring to both the patient and the family, and you can develop a rapport with them so that they will tell you the total history exactly as it is. Observe any previous medical records carefully if available. Perform a primary survey and record the vitals carefully during the triage. Bedside examination for cardinal features of critical illness. When we're talking about a critical illness, you can divide patients mainly into three categories: non-critically ill patients who can wait for some time, potentially critically ill. These are the patients who are having a serious disease but not yet progressed into a irreversible or life-threatening stage yet. But if you neglect them, anytime they can progress into a serious stage. Then is the critically ill patients which we are dealing with today. Critically ill patients are the one which, if you neglect for even minutes, there's every chance that they will land up in cardiac arrest. So how are you going to differentiate these patients? So mainly, if you look at four clinical observations, you can divide these patients into non-critically ill, potentially critically ill, and critically ill patients. Look at the appearance, how the patient is appearing. Is the patient appearing normal, like us, fully conscious, oriented, but he has some compliance? That is normal appearance. Neurological, whether he is alert, cooperating to you with your examination, whether he is giving the history. Respiratory, normal pattern of respiration with a respiratory rate of greater than 8 to less than 20 beats per minute indicates normal respiratory system, which indicates a non-critical illness. Cardiovascular system, heart rate of 60 to 100 beats per minute, a SBP of greater than 90 beats per minute, 90 millimeters of mercury, urine output of 0.5 ml per kg per hour indicate non-critical illness. When it comes to potentially critical illness, these patients will not be normal to appearance. They will be either sweaty, pale, or looking anxious. When you examine the neurological system, they will be agitated or confused, eyes open to voice only. When you are not talking to them, their eyes will be closed and they will look sick. There will be axillary muscle use in the respiratory system. Respiratory rate either less than 20 beats per minute or 20 to 30 beats per minute. Heart rate is usually patients have tachycardia greater than 100 beats per minute. There's reduced BP less than 90 millimeters of mercury systolic BP and reduced urine output which is less than 0.5 ml per kg per hour. Critically ill patients fall into two categories. Those presents already in cardiac arrest are patients who are dying or dead, and those who can be revived. The patients, those who can be revived with immediate interventions, appear gray, blue, or mottled skin because of peripheral signs of shock. They'll usually be unresponsive or eyes open to pain only. They fall into P in AVPU, or they will be having shivers. Chest is usually silent because there is not much respiratory excursions. They're not able to breathe properly. Respiratory rate is either less than 30 or greater than less than 8 or greater than 30, which indicates severe respiratory distress, or they might be having agonal respiration, which indicates a pre-arrest state. Heart rate usually extremes of bradycardia, tachycardia, less than 50 beats per minute or greater than 150 beats per minute. In ACLS terms, you call less than 50 per minute as bradyarrhythmia, greater than 150 per minute as tachyarrhythmia. SBP usually less than 60, and there will not be any urine. This very simple algorithm how to differentiate patients into non-critically ill, critically ill, and potentially critically ill. So how are you going to manage these patients? Patient has been referred to you. You did a bedside examination and decided whether the patient is critically ill, potentially critically ill, or non-critically ill. The patient is critically ill, call for help, have appropriate resources and appropriate team to deal with the patient. resuscitation using the ABCD approach, diagnostic process, and a definitive management plan. Most of the time, these patients will be admitted to ICUs in the hospitals. Then the second category, potentially critically ill patients. Examine them thoroughly, make a definitive plan, reappraise the treatment, enhance the monitoring, and reappraise the diagnosis. Most often, these patients will need a high definition unit admission, high dependency unit admission, HDU admission. Non-critically ill patients, take complete history, do a complete physical examination, diagnose, and definitive plan. These are the patients who can either be discharged or be need a ward admission. Now we'll focus on how to manage the critically ill patients. Immediate measures have to be taken to prevent death. Call medical emergency or code blue team or a senior ED doctors whenever is available. Follow the ABCD approach to prioritize systems management. If a derangement is found in one system, suppose there is a problem with airway, you will not proceed to assess breathing unless the airway has been managed. Once airway is managed, then you go into breathing, assess breathing, manage breathing, go into circulation, assess circulation, manage. Disability will be managed when you manage airway, breathing, and circulation. And environmental control is one of the most important steps in managing the critical ill patients. So, how are you going to manage airway? Basically, what is an airway? Yes, airway is nothing but the passage that conducts oxygen from environment to the lungs. Look for patency, that is whether air is freely moving in and out of the lungs. Look for any noisy breathing, secretions or oropharyngeal trauma with active bleed, which indicates potentially obstructed airway. Position the airway appropriately, suction out any secretions, and prepare for intubation whenever necessary. Breathing management. Proceed to breathing once the airway is managed. Look for bilateral equal chest excursions, chest movement, air entry into the chest. Count the respiratory rate. As I already told, respiratory rate less than 8 or greater than 30 is an immediate indication for breathing management. Bradypnea and tachypnea indicate very serious illness. Initiate oxygen therapy and titrate to a saturation of 94%. Use appropriate oxygenation devices. We'll be learning about how to manage airway, breathing, all these things in the coming lectures. For now, you should know how these things should be managed in sequence. Circulation, look for failure of the skin, mottling and discoloration, check the pulse rate, capillary refill time, blood pressure, dryness of mucous membranes, loss of skin texture, which indicates low volume status. Tachycardia, feeble thready pulse, along with other cutaneous signs, which we discussed earlier, indicate circulatory shock. Hypotension is a late feature. Most of the patients with shock will not have hypotension because of the compensatory mechanisms. Patients with a normal blood pressure can have shock. Also, patients who are hypertensive, even though their BP is more than 100, their baseline BP would have been a lot more than that because they are on antihypertensives. Their target BP is 140. They would have settled at 140. In them, even a systolic BP of 120 millimeters of mercury should be considered as in shock if the features of shock are present, and they should be treated accordingly as critical patients. Action an IV access, preferably two large bore IV cannulas. Peripheral access is not immediately available. Call for help for an IO access. If you are capable of securing an IO access, secure an IO access as early as possible. It is very easy and can be done in both pediatrics and adults. It takes less than a minute to secure the IO access. Usually, veins in the antecubital fossa and the external jugular veins are more easily accessible, especially in those patients who are shocked and are also good for volume registration. The common notion that central venous line is more preferable for volume registration. Peripheral line is not useful for volume registration. this wrong. If you are going to give drugs like vasopressin, epinephrine, dopamine, you need a central line. Norepinephrine can be started through a peripheral line and then be converted into central line. So for volume resuscitation, because of the larger diameter and the shorter cannula, a peripheral cannula is preferable. If circulatory shock or hypotension is present, you aliquots of 250 ml fluid bolus or 10 to 15 minutes. Assess the response, and as we discussed in the volume status class, you can give more fluids based on the need. If the patient is not responding to fluids, you can go and start the vasopressors early in the course. If you are hitting with vasopressors, hit hard and hit early. This is the dictum. If you are thought of thinking starting vasopressors, start at maximum dose and then you can come down when the patient's BP improves. Arrange for blood transfusion as appropriate. Management of disability, use GCS or AVPU scale. Observing the patient's response to a verbal or painful stimulus can rapidly assess level of consciousness. Check capillary blood glucose and exclude hyperglycemia. Check temperature and manage with paracetamol or external. Management following immediate resuscitation. Most of the time, once resuscitation is done in the ED, the patient stays in the ED for longer duration, the patient will be neglected. Keep in mind, there are three types of volume responders. Non-responders, you don't have to worry about them. They are patients who will not respond and eventually they're going to die. Irreversible damage is already developed. Second category is transient responders, where the patients will respond to initial fluid management or initial resuscitation and they will be neglected and they will go back into critical illness again. Third is the patients who respond and improve with fluid management. You need to take a focused history, control pain appropriately to facilitate communication, use universal pain scale to assess and manage the pain, avoid prolonged irrelevant examination which causes inconvenience to the patient and increases the risk of potential illness. Perform a blood gas analysis to look for ventilation and oxygenation and circulation, send appropriate investigations and obtain the results as early as possible. Diagnostic imaging like ultrasonography can be done bedside unless the patient is completely stable. It can be transferred to the radiology department. Always sought advice from senior staff and doctors when you are dealing with a patient who is critically ill. Most commonly neglected part when you are dealing with a critically ill patient is the communication. If you can communicate properly with the family and the patient and the authorities, you can avoid so many risks and you can do a completely normal practice. Communication with the patient and family is important step in management. Explain the condition clearly and in the language they can best understand and explain completely without leaving any blanks so that they will understand completely and they can trust you. Explain the complications, explain the expected outcomes, and the line of management you have planned, and if any alternatives available, explain them. Use simple local language as much as possible. Don't use medical jargons when explaining to the attendants. Explain about the costs involved and available alternatives for continuation of the treatment. Show compassion and empathy towards the patient and the family. Never ever forget documentation. Documentation of the communication of the documentation is very, very crucial to avoid any medical legal complications at a later date. Then coming to management of potentially critically ill patients, this category of patients are quite difficult to deal with because identification of potentially critically ill itself is a problem. They can worsen any time during the course if left unattended. Reappraise the admission, diagnosis, and treatment by following stepwise assessment and focusing on the vitals. Assess repeatedly as mandated by the clinical situation. Initiate continuous multi-channel monitoring so that they will be always monitored and you will not neglect them. So to summarize, patients who develop critical illness are often suboptimally managed. You know the causes of suboptimal management as I outlined earlier. Cardiac arrest is often preceded by unrecognized physiological deterioration over a period of time. It doesn't occur all of a sudden in most of the diseases. A bedside examination based on observation and simple physiological measurements can be used to rapidly screen for critical illness, follow a systematic approach, and have high level of suspicion. In critically ill patients, dysfunction of the airway, breathing, and circulation are the most important culprits that lead to immediate death. And so, assessment and treatment should focus on these systems. Potentially critically ill patients need diagnostic reprisal, enhanced monitoring, and regular review. Help from senior doctors should be sought early to refine the diagnosis and treatment and the resuscitation status of the patient. Effective patient-provider communication can improve engagement rates by 60%. Thank you. Don't forget to subscribe and share the videos for wider dissemination. Thank you again.